Okay, this is going to be the lecture over chapter 14. We're going to be looking at electron beam therapy. Now, electrons are the kind of, it's not really the mainstay, it's not the bread and butter of a lot of radiation therapy, but the ability to be able to treat with electrons is very important because there are going to be certain cases in which that is the method that you really need to get the best outcome in order to treat certain diseases. Now, they're not as common as the photons, but or as photon plans. I know that from experience, but I will say that they are important, and there are certain characteristics about electrons that you need to know. Um, there's an entire um, presentation that we'll have here that we'll go over some of the highlights on. But some of the key things that I need you to know are going to be summed up here in the key points at the end of the chapter. The clinically useful energy range is going to be between 6 and 20 MeV. And at those energies, electron beams can be used for treating superficial tumors up to 5 centimeters in depth. Rarely have I seen a 20 actually be used. Most of the time, you're going to be looking at anywhere from a 6, maybe a 9, maybe a 12. But normally, and when it comes to treating things that are superficial, you're going to be looking at something with a 6 to 9 and some amount of bolus. You can go deeper than that depending on, what might lie behind that particular tumor. And you can certainly go up to 20 if need be, but you're not going to be getting a very homogeneous dose that deep. But it can be done. So a lot of machines are going to be commissioned, like one of the places that I work with consistently. We have energies commissioned up to, I want to say 18 MeV. But in the 10 years that I've worked there, I don't ever remember putting together a plan for an 18 MeV beam. So that's something to bear in mind. Electrons are going to interact with matter through a process of ionization and excitation. These are the most predominant interactions in soft tissues. You can also have bremsstrahlung, which is more significant at higher energies, and higher atomic number materials, higher Z materials. You can also have a third type of reaction, which is elastic scattering by atomic nuclei and elastic scattering by orbital electrons. And we'll get into those a little bit later. The collisions resulting in secondary electron production or delta rays are possible, but they're kind of rare. The energy of clinical electron beams is specified by the most probable energy at the surface. The rate of energy loss with depth in water or soft tissue for clinical electron beams is approximately 2 MeV per cm. And yes, that is something that I am going to have on assignments or quizzes, exams. That is a very, very important quality there, and I want to make sure that you guys have that. Electron beams have a modest skin sparing effect, which gradually disappears with increasing energies. The lower the energy, the sharper the dose drop off beyond the therapeutic range. Depth dose distribution can be determined by ion chambers, diodes, and film. The percent surface dose increases with increasing in energy, getting back to what we had talked about there before. Energy applicators are necessary to collimate the beam close to the patient's surface, and we'll get into that. Acceptable beam flatness is achieved by dual scattering foils. PDD, percent depth dose, and output vary with field size. If the field size is smaller than the required for LSE. Virtual SSD determines beam divergence. The effective SSD gives agreement with the inverse square law. Beam obliquity changes the PDD, giving rise to an increase in dose at D max and a decrease in a depth beyond dose. In other words, if you're not perpendicular to the surface and you start changing the direction that you want that beam to go in, this is what's going to start to happen. You're going to see an increase in dose at D max and a decrease in the depth dose beyond that. You're somewhat limiting the ability of the beam to treat, and that's what's going on here. But in some instances, you might want that. Steep changes in surface contour gives rise to hot and cold spots. Sometimes that's unavoidable. Sometimes you're going to have a steeper change in a surface. And so you're going to have some spots that are going to be getting less dose than normal. Maybe in some cases more than what you might expect. So if you have large slabs of inhomogeneities, then PDD corrections can be made using CET or effective depth based on electron density. In other words, the number of electrons per cubic centimeter relative to water. Around small inhomogeneities and at the steep edges of heterogeneities, electron scatter gives rise to hot and cold spots. In other words, it's not going through material, just the same material smoothly. You're going to run into areas of bone, or you may run into areas of air, that kind of thing. And so it's going to affect the range, the effective range there of what you're going to be able to treat. Adjacent electron, or electron photons give rise to hot and cold spots due to beam divergence and interfield electron scattering. And basically what that's referring to is that if you put two electron beams very close together, electron beams have a characteristic in which they bow out at the edges. So your isodose lines are going to, rather than with a photon, which is going to be a photon beam is going to have more of a forward pointing dose, and you're not going to see a bowing effect at the edges. That's not true of the electrons. The electrons will bow out along the edges. Now, the reason that's important and the reason you need to keep an eye on that is that when you start trying to junction electrons, you need to factor that bowing effect in. Now, a lot of planning systems like Eclipse and even Pinnacle, Monaco, or whatnot, a lot of systems will try to take that into consideration as best as they can. But by the time you start combining those junctions with obliquity and we haven't even talked about it yet, but you start adding bolus onto it, you can come up with a real complex situation there. Bolus may be used to build up surface dose. In other words, let's say that you don't, in some cases, you don't want an electron penetrating too far in. Maybe you've got a lesion on the scalp or something that you want to treat. Sometimes adding a little bit of bolus there prevents the electron beam from penetrating too far into the patient. So that's a way of preventing that. Field shaping can be done with lead or Saraband cutouts so that you're not blasting away at, with an open field. Minimum thickness of lead required for approximately 5% transmission of dose is approximately the energy of the electron beam divided by 2 in millimeters of lead. So if you have a 6 MeV beam and you want to knock down the amount of transmission through a little portion there, and you're using lead to do it. You want to bring it down to about 5%. Then you're going to take that 6 and you're going to cut it in half. And so you need about 3 millimeters of lead. The internal shielding is possible in some cases, but some dose enhancement due to backscatter from lead must be taken into account. Now, I don't think any of you guys are going to be doing any sort of electron arc therapy. If you do, let me know. I have been in this particular business in either community or hospital clinics or even university clinics for over 15 years now. I have yet to see an electron arc be done. It's not something you guys are going to run across. However, it may be on your boards, so it's good to know about. Electron arc therapy is feasible for tumors along curved surfaces, but you're going to have some custom shielding that is going to be able to define the treatment field and sharpen dose distribution at the field edges. This is also something here that is not really done so much anymore. I think mycosis fungoides is actually something that is treated differently now than it used to be, but there's nothing said that you can't use electron irradiation in order to be able to treat it. So total skin electron or TSE irradiation is a useful technique for the treatment of mycosis fungoides. Considerable dosimetry is required before commissioning the procedure for actual treatments. Yeah, there's a lot that goes into that. The final statement here where it says pencil beam algorithms are currently the algorithms of choice for electron beam treatment planning, that has been superseded. It has been superseded by Monte Carlo. I know that with the version of the treatment planning system that I have, it's Electron Monte Carlo. That's what we're using. Pencil beams used to be used even a good 10 years ago, but those models are, at least with the planning system that I use, are being replaced. That is a short summary of what it is that's going on in chapter 14. And I will go over the slides here to kind of give you a little bit of a better idea in depth as to what is going on in this chapter.